Prepare to experience the strongest radio allowable by law. Secrets will be revealed. Myths dispelled. From the studio gym where excuses never apply, it's Superhuman Radio with your host, Carl Lenore.
Hey, welcome back to another episode of Superhuman Radio, the beginning of a new week. This is January 11th. It's a Monday. We have a fascinating show planned for you today. During the first hour, we're going to be talking about ketamine. Ketamine is being used to treat major depressive disorder. We're going to learn what ketamine is, and we're going to learn about a new study that shows a protein that may be the key to making ketamine work better. Later in the show, we're going to be joined by Alex Leaf, who's been on the show before. He actually worked for Superhuman Radio many years ago, discussing the potential implications of a COVID vaccine during pregnancy. Obviously, there's no data to show that it's dangerous, but there's no data to show that it's safe. And we're going to explore this concept with him later in the show. Of course, before we do anything else, we have to thank our title sponsor, and that's Legendary Foods. And they have their new tasty pastry, which is birthday cake flavored. If you haven't tried it, you're missing out. 0 sugar. It's flaky like the crust that you'd find on an apple turnover. It's delicious. 20 grams of high leucine, high quality protein, not overloaded with fiber like so many healthy snacks are today. It's just a superior snack. And I'll tell you, you better buy a couple extra boxes because when your kids find them, they're going to want to eat them. And don't tell them that they're good for them. Go to shrnetwork.biz/legendary. Use the code SHR10 to save 10% off all of your products from Legendary Foods. Now we'll bring my guest on, and I'll just get some banner things set up here. Dr. Argel Aguilar-Valles is with the university in Canada. Talk about your university, first of all. Let's plug the institution first.
Hi, Carl. Thank you very much for this opportunity. I'm in Ottawa, and the university is called Carleton University. And it's a research-intensive, comprehensive university here in the capital of Canada.
Okay. So before we even talk about ketamine and what research there has been before this research, we've already getting questions from listeners. Let's see if I can get one up here. Well, for some reason, it's not showing up, but I'll read it from the internet. It's from Josh Bruner. He says, what does ketamine affect? Does it affect serotonin or something else? What is ketamine, actually? Wasn't it an anesthesia or something like that at one time?
Yes, it is still used as an anesthetic. So it was created in the lab in the 1950s, and then in the 1970s it was started to use as an anesthetic for general surgery. And even currently, it's one of the anesthetics that is applied for children when they go into pediatric surgeries. So it's still used as that. But after its discovery, it was also the realization that ketamine can cause these hallucination effects and dissociative effects, this sort of like a detachment from reality sensations that can be appealing particularly for some partygoers. So it was started to use as a recreational drug, and that's the main reason why it was classified as a controlled substance in practically everywhere in the world. And it was much later in the 90s when the potential for treating depression was discovered.
So, I mean, anything that would make you detached sounds like it could also be beneficial to be administered immediately after a traumatic event, because we know that benzodiazepines are used periodically when someone undergoes a horrific event, and it helps make you more distant from the memory over time, and you don't have the traumatic effects long term. Do they use ketamine that way as well?
No, it hasn't been used that. It's been tested as a potential treatment for PTSD, for post-traumatic stress disorder, and it actually has this very important effect that it reduces suicidal ideation very rapidly and very effectively. So it does that in PTSD patients as well as major depressive disorder patients. But it's usually administered after, not immediately after the traumatic event. It's actually the only approved by the FDA and other health agencies around the world. The only approved use that we have is for what they call treatment-resistant depression. So when you've been diagnosed with major depressive disorder, and you've been through a couple of rounds of typical antidepressants, SSRIs, the serotonin reuptake inhibitors, and you don't improve your state. And usually these trials and in a patient will go on for 6 months just to see if the patient responds or not. And after going to a couple of these medications, if you haven't responded, then you might be eligible for a ketamine treatment, and it has to be administered in a clinical setting because they need to monitor that you don't have any excessive the dissociative or hallucinogenic responses that can put you in some sort of danger. So it's really in these specific circumstances that is being used. But there are several clinical trials indicating that it's effective for PTSD and other psychiatric disorders. The problem is that because of the, oh, sorry, go ahead.
No, go. You may be going to mention what I was going to ask. Good.
Okay, no, that the problem it's not recommended for when you're first diagnosed with a depressive episode. It's not the first line medication. Your physician or your therapist will go usually first with an SSRI, and if that works, then you will stick to that. It's up to this point, because this potential of abuse, it's really only recommended to those cases where there's really nothing else have worked so far.
So I want to talk about the abuse first. So first of all, it's widely used in the penitentiaries and prison systems because the prisoners want to escape being prisoners. And there's a phenomenon when you take an effective dose of ketamine, you go into a K-hole, they call it. And the K-hole is almost a catatonic state, is it not? It's like you become like a zombie, right?
Yeah, that's correct. It's sort of like you perhaps can see it as a preamble to anesthesia, right? Anesthesia is putting you in this deep state sleep. It's not analogous to any of our normal or typical sleep states, but it's an anesthetic state. So when you are abusing it, you can reach certain, like some sort of in-between state or something close to anesthesia that, indeed, it helps you evade the reality for the moment. It is unclear whether, the doses that are used for depression are what we call sub-anesthetic. So they're really much lower than it would normally take to induce these dissociative or these hallucinogenic states. So the doses are considered in that regard safer, because you don't reach that, obviously. But if you give it, if you will prescribe it for people to take at home, there's always a risk of abuse. So that's why there's still a lot of regulations in place.
Now,
but
is it habit forming? Is that why? So I know people who have used ketamine in a clinical settings for depression, and they all say the same thing. You feel horrible. It's a weird feeling. They can't really explain it, but they don't feel. It's not like you feel salvation or relax, or they make it sound like it's a very uncomfortable high, if you will. So why would someone develop that's a stupid question, because I did a lot of drugs when I was a kid that didn't make me feel comfortable. I just answered my own question. Never mind.
No, but it's true. I mean, when you are, your first experience with a lot of the drugs of abuse, it could be either, very good, and then you want to pursue that, or it could be really bad because you're naive to it and you're not really know what to expect. And a lot of these hallucinogenic drugs not only ketamine, but I'm thinking, more typical hallucinogenics like LSD and psilocybin. The reaction, even cannabis, the reaction that you have to it can depend a lot on the context. So if you are in a context that for some reason makes you feel stressed, your reaction can be quite bad. But if you are in a context that can be safe, the reaction can be different. And yeah, so there's all sorts of people out there, and all sorts of experiences. So for some people, just taking certain doses may cause something more more pleasant, or more, even if it's not pleasant, it might be just interesting, or if it's helping you evade something that is really haunting you. I mean, I can see why people will go for that. Yeah,
that becomes the reward. So
yeah, exactly.
And lastly, about ketamine, before we talk about your research, because I have a feeling that what your research has discovered will create more effective dosing than this kind of we'll try this, we'll try that. So are there unwanted effects of ketamine, short or long term?
Well, it has, apart from these dissociative states, it has, as we discussed, the potential of abuse. That's another effect that is not desirable. It can also interfere with memory formation, because its primary target, it's one of these neurotransmitter receptors that are very important for the formation of memories. So acutely, when you administer ketamine, it can have this effect where interferes with whatever is happening. Maybe you won't be able to remember it. Some sort of like a short-term amnesia. Excuse me.
Yeah.
So that's why it's not it's a powerful treatment, but it has many psychiatrists still considering some sort of dirty drug, like something that, yeah, we might use it in case we don't have any more options, but if we can find a better alternative that does the same without all of these side effects, that will be great. We can go for that.
So now talk about your research. So your group set out to better understand how and why ketamine works, and this could actually unlock better dosing and better protocols. So talk about your study. What was the desired endpoint of your study? First of all, what were you trying to find out?
So from a more like pure research perspective, we want to understand how it works. And obviously, the more applicational reason to pursue this is because understanding how some of these new treatments for something like depression work, then you can, as you mentioned, you can envision or you can try to design something that might be safer, that may be devoid of all of these undesirable side effects that many of these, ketamine has on people. So the idea is to identify what's the requirement in the brain in terms of what cells, what molecules are really essential for the antidepressant effect. If we can pinpoint all of these basic mechanisms, these molecules, then maybe we can try to use that information to, as you said, either use a better dosage that stimulates these antidepressant responses without triggering the other undesirable effects, or use an alternative, a similar molecule that has more specific effects than ketamine does. So that was sort of like the big idea behind motivating us to do this study.
Okay, so how was your study designed?
So we work. We are a basic research lab. That means we don't work directly with patients. We work in animal models. So we use animal models, and in this particular case, we use mice. They are a great tool for research because we can do genetic manipulations on them in order to, prove that something that you suspect is involved in the effect of ketamine, it's involved in it. So you can take it out. This is what we call a mutant mice. It sounds like very sci-fi and very perhaps scary, but what it just means is that you go in and take a little bit of their DNA out, and basically they are no longer expressing or producing certain elements in their body. So when you remove some of these genes, they may not have a big effect in the mouse. The mouse can, be born, grow, reproduce, and die almost normally. So in this case, we were using a certain type of mice that have a protein missing. And I can explain a little bit more what this protein is, but that's sort of the model. And then how do you measure depression in a mouse? That's the $1 million question, right?
I bet I can guess, right? They don't move. They don't want to have sex. They go sit in the corner and they just stay there. That's it. Exactly.
A lot of what you will call passive responses to any stimulus that you give them. So indeed, and it's sort of like an easier way to elicit these things will be, for example, to stress the mice. You stress them for several weeks in a row, and then all your mice or most of your mice will become these really fragile looking and passive animals, because basically you are trying to mimic what happens to many people. Like they face a lot of chronic stress. Chronic stress is really a major factor in developing this disorder. So yeah, what we measure at the end is several behaviors of the mouse. You put them in challenging circumstances, like there's a couple of tests where you, for example, put them to swim. Mice are natural swimmers. They have no problem swimming, even if they never encounter water in their lives. So you put them in water, they will swim. But a depressed mouse will swim less in a confined area, in a confined container that they know they realize they can't escape. And a chronically stressed mouse will just be more passive and just sort of float there. And if you administer them ketamine or other antidepressants, you will then trigger more active behaviors. The mouse will start again sniffing around, moving around, trying to find an escape route. So this is some of the behavioral tests that we use in rodents to sort of screen for potential antidepressants, and also to see what components of the animal's brain would be important for the responses. And then, so we knew before that there was a protein called mTOR. It's an acronym that basically means mammalian target of rapamycin.
We talk a lot about mTOR on the show because
fantastic.
Well, all about muscle, but also when we talk about senescent cells and how mTOR affects senescent cells, and so my audience is very well versed in mTOR.
Oh, fantastic! So mTOR, as you mentioned, it's actually involved in a lot of metabolic responses. So it's activated by several stimulus that has to do with energy management in a cell. So in the brain, it also happens. And but as you may know, and your audience may know, mTOR regulates a lot of functions in a cell or in an animal. So you can, it's more than a dozen different functions, if you will, and the molecular targets, the different proteins that are affected by mTOR there's many of them. There's probably close to 100, if not more. So obviously, it was demonstrated a while ago by the group of Ron Dunham at Yale University that if you block mTOR using rapamycin, which is this blocker of mTOR, it basically kills the function of mTOR, so to speak. Then you wouldn't be able to elicit these antidepressant effects of ketamine. So what they demonstrated was that mTOR in the brain, it was required for the role of ketamine. Now, what we in the lab, I was working as a research associate with Dr. Nahum Sonnenberg at McGill University when we started this study here also in Canada. And he's been working with one of the targets of mTOR, one that controls a process called protein synthesis. So all the factory in the brain that produces proteins that are important for every function of the neurons and other brain cells.
Even in the muscle.
Yeah, exactly. So it's everywhere in the body, and in the brain it's really important for example, again, for formation of memory. So every time you form a new memory, this pathway is activated, the mTOR. And the proteins that are important for that are called 4-EBPs. Again, it's another acronym. It just means EIF4E binding protein. And EI4E, it's something that controls protein synthesis in the brain. So these 4-EBPs are blockers of protein synthesis. And when mTOR activates them, you remove the brake and you can have protein synthesis go ahead. So we suspected, okay, this is a really key effector of mTOR, a really key factor that is controlled by mTOR and that controls a really important function for learning and memory and for induction of something that we call synaptic plasticity, which is the ability of the brain to sort of change the connections between neurons when it's needed. For example, when you learn something new. But it also seems to be important for your mood regulation. So if you're chronically stressed and you're feeling depressed, most likely the mTOR activation is decreased. So what we suspected that ketamine was doing is increasing the activation of mTOR and increasing protein synthesis and allowing all of these plasticity events that occur normally in the brain to resume. Exactly.
Right.
So then how do we prove this? Well, we take one of these mutant mice. They're mice that lack the 4-EBP. So we remove the 4-EBPs from the brain and we treat them with ketamine.
Now, I want to ask you a question. So these transgenic mice, they have no 4-ADP from birth, or do you then, once they're born, you administer a drug that turns the 4-ADP off?
So we had two different, actually several versions of the mutant. One that was completely from birth, not having the 4-EBPs, and others that were specifically knocked out from specific populations of neurons. So we have different types of neurons in the brain. It's not only one general type. There's many, many different. But you can classify them roughly as excitatory neurons, neurons that activate other neurons, or inhibitory neurons, which are neurons that inhibit other neurons. So we targeted these two major populations. So we remove it from either of these populations and we look for the responses to ketamine. And we always compare to what we call a wild type animal, an animal that has the 4-EBPs intact and that responds in the way that we expect to respond to ketamine, which is increasing all of these active behavioral responses and increasing all of these synaptic plasticity events in the brain. So those were our major endpoints, the behavior and the synaptic events, plasticity events in the brain. So when we remove the 4-EBPs, as we had suspected, the mice were completely resistant to ketamine. They no longer were responding, and that strongly indicated that this protein was required. Now, as I mentioned, what's important is where this is happening. The brain has many different cell types. I just mentioned, for example, neurons can be roughly classified into two types. So that's why we decided to look at where is this event happening, in which cell type it's happening, and maybe we can have, this will help us to define better how ketamine is working. And we remove them from either the excitatory or the inhibitory neurons, and to our surprise, the major effect happened in inhibitory neurons. Why was this surprising? Because inhibitory neurons are roughly account for only about 10% of the neurons in a brain, roughly. So it's a minority of the neurons, but their role in controlling the way our brain works, it's fundamental. So if you have deficits in or problems with some of your inhibitory neurons, you can have major things like epilepsy, where the rest of the neurons that are excitatory, they don't have a sort of like a checkpoint by these inhibitory neurons, and things go out of control, and you can have these seizure events. That's an extreme case, obviously. But when we knocked out the 4-EBPs from these inhibitory neurons, where we basically ketamine was no longer able to work. So it really indicated that this protein in these neurons is sort of like one of the essential components that you need in order to have an antidepressant effect by ketamine. And this is one of the major findings of the study.
This is so fascinating because you have traversed so many areas of interest of this show that, the fact that, so I want to make sure I understand a couple things real quick.
Yeah.
So suppression of mTOR can affect memory formation.
Yeah.
Okay. I take 6 milligrams of rapamycin once a week to rid my body of senescent cells. But Dr. Mikhail Blagoslowny the physician who's done 30 years of research on senescent cells and mTOR and rapamycin. I texted him one day about a year and a half ago. You know, I'm a somebody who likes to build muscle. So I'm 230 pounds. I eat about 300 grams of protein a day, high leucine protein, which turns mTOR on. And I said, has anyone done any research on taking rapamycin but eating high quality protein? And what is the net effect? I have a funny feeling that mTOR is not being as suppressed in me as it is to a person who only eats 60 grams of protein a day. But that's another discussion. The other thing that I thought was interesting was when you invoke the epilepsy discussion. We know that the ketogenic diet, which increases ketones but suppresses the brain's need for glucose, and help suppress epileptic events, which leads me to question what nutritional roles we see in people with depression. Because if you're not getting enough protein and you're not creating enough mTOR and you're eating a lot of glucose producing foods, and we know that there is now something called type 3 diabetes, where it's exclusively insulin resistance of the brain. Do these people also suffer from depression at a higher rate?
So a couple of things there. First, regarding your rapamycin intake, it's always on the dose, right? Because you're taking it through your to your digestive system. It has to be absorbed. So actually, rapamycin can have a lot of effects in the gut itself, and whether it reaches the brain, depending on how much you take, that's debatable. It might not, at the concentration that you're taking, it might not be enough to reach the brain. It might be broken down before, and you don't have an effect, a direct effect on the brain. You can affect other things, obviously not affect, but modulate
other tissue. Yeah,
exactly. And now regarding the yes, there is a lot of links with obesity and poor diet, like particularly high carbohydrate, high fat diets combined in eliciting depression. So there is a big link there. Now, one thing that happens with depressed people is that with major depression disorder diagnosed people is that you can have both extremes. People with increased appetites and increased body weight, but you can also have population of people that has decreased appetite and decreased body weight. And both extremes have been associated with depression. This is where the confusion comes and actually just indicates that what we call major depressive disorder is probably a collection of different disorders that we lump together because they resemble somehow, but they might actually be different, and the causes for each individual case may be different. And this is, the discovery of ketamine and its effects, it just emphasizes that different people respond differently to treatments, and that we should be really considering this more personalized approach when treating somebody with a disorder. So all our definitions of these psychiatric disorders need to be refined to better reflect the reality, which is that there is a great diversity of people out there that are all lumped together in the same diagnostic category. But yes, indeed, like a poor diet, it's associated with increased depressed mood, and it can be a risk factor for developing major depressive disorder.
I want to take our first commercial break. I've got so many questions now that's just amazing. I want to talk about inflammation. I want to talk about the gut microbiome. It's interesting because I'm one of those people that when I was young and I would get depressed, a girlfriend would break up with me, I would lose my appetite. And I know other people who, when they get depressed, all they want to do is eat. So that's a fascinating dichotomy there, that people are still depressed, but there's got to be, I don't know. It's just very, very intriguing to me. Very intriguing to me. All right, we're going to take a quick commercial break. We've got lots more to discuss. Stay tuned. You're watching and listening to Superhuman Radio.
New Mass Pro Synthogen X2 just upped its own legendary game to distance itself even further from the rest of the
a total war. Sign up for their new transformation challenge and win $10,000, or shop for apparel that people at the gym will know that you are serious about your training. Need a testosterone booster that works? Check out Boomstick. Whatever you need, you'll find the best quality supplements on the market at Redcon One. Go to redcon1.com. That's REDCON, the number 1.com, or go to superhumanradio.net and click the Redcon One banner ad today. Getting a massage post-workout is a proven strategy to facilitate better recovery. Getting to a massage therapist can be difficult and expensive, especially in these times. The solution is the Meteor, a heated massage ball from Milestorm. Reduce pain and soreness and expedite recovery with the Meteor's research-backed vibration settings and therapeutic heat. It's convenient for travel and works on any body part. Go to shrnetwork.biz/Meteor and use code SHR15 for 15% off and free shipping if you buy 2 or more. Start recovering better today. By now, you're aware of the cognitive benefits of nootropics. My friends over at Pure Nootropics are giving my listeners 10 to 30% off their already great prices on over 70 high-quality nootropics. Stock up on DHM so you can feel good after your holiday celebration, or try the Superhuman Stack to boost your brain and energize your day. Go to shrnetwork.biz/pure, that's PURE, and start saving today. Are you ready to change the way you age? Of course you are. That's why you're here. Juvicel is a new first-of-its-kind dietary supplement that includes 10 key research-backed ingredients shown in studies to support lifespan. Things like resveratrol, fisetin, quercetin, pterostilbene, sulforaphane, turmeric, all in a single dose. You may have some of these ingredients already, but Juvicel is the first to combine them all into a single product to support your lifespan. It's vegan, non-GMO, and sustainable. Live better longer with Juvicel. Go to shrnetwork.biz/live better. Use code SHR and save 20% off today.
Spit that out right now. This is the Superhuman Channel.
Hey, welcome back. Those of you who've been fans of wow, what happened to my camera? Look, my fingers are invisible. Those of you who've been fans of the show for a long time know that I am not a fan of the scale. I've complained about scales a lot. I say they really don't give you any information. You don't know. You can take 2 people and put them on a scale. They both weigh 200 pounds. But one person is very, very obese and has very little muscle. And the other person has a lot of muscle and is very, very lean, still 200 pounds. But there's a new scale that I'm crazy about. I've shared with you, if you're following me on Facebook, that the past couple of years have been a pretty slow slide downhill in my health and training because of my 2 surgeries in 2019. Well, I've made 2021 the year for me to get back to my all-time physical health and strength. And one of the things I've started using is something called the DARA scale, and it's made by FitTrack. The reason I'm using this scale is because it tells you so much more than just your body weight, just the effects of gravity on your body. It gives you up to 17 vital health metrics, including your muscle mass, your bone mass, your fat mass, even hydration. Everybody's taking all sorts of hydration supplements today, but the reality is that this scale actually tells you how hydrated or dehydrated your body is. Over 600,000 people are pleased with using this scale and say that they got healthier faster and reached their goals faster, 8 times faster than without using the DARA scale. If you go to getfittrack.com/SHR, you will take 50% off your order. Plus, for a limited time, my audience gets an additional 10% off. That's getfittrack.com/SHR for 50% off, plus an additional 10% off. Don't miss out on this. This is really, this is the first scale that I really like, because it gives you so much more information than just your body weight. Check it out. All right, now back to the discussion at hand. Give me a second here, and let me bring back my guest. We're talking about ketamine. We're talking about how it can be used to treat major depressive disorder. I'm going to adjust my camera as we talk. So one of the things that I wanted to ask was, I've heard people say that when they use ketamine for major depressive disorder, it wears off after a while. The beneficial effects wear off. Would your research help us understand how to make it last longer?
Not directly, not yet, but that's where we think we're heading with this. Yes, you're correct. Initially the treatment was a single injection, a single intravenous injection for ketamine, and people saw effects for about a week, which is remarkable because, for example, SSRIs you have to take for several weeks or even months to have a sort of like reach a peak effect. So ketamine was acting really fast, and one single shot was lasting. So what actually people are trying now in the clinic is several doses of ketamine. The version that's approved for treatment-resistant depression is actually a nasal spray. So it's much easier to administer than having to go intravenous. But still, it's the same sort of like effect that is for a few days, and then it sort of like wears off. Some people will remain sort of like in a better state for a longer time, but you need some sort of like a booster or reinforcement eventually. And what people have tried in the clinic is trying several doses that seems to still work. And again, we're talking about doses that are very low compared to what you will need to take in order to have one of these more vivid hallucinations or dissociative state. So these are doses that are much lower than that. So, but what we discovered is that these proteins were not only important for the initial effect, the rapid effect that you see, you observe within minutes. We observe the same in mice as in humans. Within minutes, you see a change in their behavior, and it lasts about the same, about a week. And this protein is important for both effects. So it's not only relevant for the rapid effects, but also for the sustained effects. So what we need to do now is to identify what's being regulated. By regulated, I mean these 4-EBPs, they control the levels of many other proteins. Like they control protein synthesis, but it's not a general effect. It's not protein synthesis just like of every single protein that a neuron expresses. It's right. A specific population, and we haven't identified that population. So that's where we need to investigate. What is this population of proteins, this specific group of proteins that is controlled by the 4-EBPs that is necessary for the ketamine? And I think that will be key to be able to extend, for example, the effects of ketamine. Something that recently was reported, however, in a clinical study, in a study with people with depression, was that actually it was somehow unexpected. So the idea of the study was to test whether rapamycin will block the effect of ketamine in humans in the same way that it happened in mice. And this was in a group in University of Maryland in Baltimore. And they gave rapamycin in actually they just dissolved it in orange juice, if I'm not mistaken, and they gave it to people. Surprisingly, the acute effects didn't change. Like the effect of ketamine was still there. And then when they looked at those people a week later, what they saw is the number of people that was still showing signs of improvement was much larger in the group that received the rapamycin. So contrary to what happened in mice, which we still don't understand why this massive difference, rapamycin seems to be able to extend the effect of ketamine.
I have an idea I want to share with you.
Yes.
So, rapamycin changes the inflammatory landscape of tissue.
That's right.
And there's good research. I did a show probably 6 years ago, maybe 7 years ago, that linked major depressive disorder and chronic inflammation hand in hand. That inflammation gets to the brain, not everybody's brain. Some people's blood-brain barrier seems successful, but once the blood-brain barrier is breachable, the inflammation gets to the brain, and the inflammation is what's causing and we know that reduction of senescent cells reduces cytokines and chemokines and all that sort of stuff. So it may be working better because while the drug is doing its job, the inflammation landscape is dropping simultaneously.
You are correct. That was actually the first guess that many people suggested when they saw that study. And the authors, unfortunately, they weren't able to measure the cytokine levels in these patients, which is unfortunate. But that is indeed a possibility that the peripheral, when you administer rapamycin, is having, as you said, effects on your body systemically without necessarily reaching the brain because it's broken down before that happens. So it can reduce all of these inflammatory signals. That actually is one of the few things that it seems to be more widely, characterize major depressive people. We talk about how some people, eat more, some people eat less, some people sleep more, some people sleep less, and so on and so forth. But a great amount of people with major depressive disorder has these elevated cytokines and elevated inflammatory markers. And actually, chronic inflammatory diseases are linked to a higher risk of developing depression and so on and so forth. So yes, it is possible that it can have this effect there, and it can extend by that means or facilitate somehow the effect of ketamine, the effect that ketamine is having in the brain.
So rapamycin has a 3-day life in the body. It's a pretty long-lasting drug. How long does ketamine last once it's administered?
It's a few hours. Like if you measure it, if you try to measure ketamine levels the next day in the blood, or even in mice, you can go and measure in the brain. Next day is already gone. So the peak is 2 or 3 hours after injection, even shorter perhaps. The peak, I think it's fast. It's like half an hour after the injection in the blood and in the brain. And it starts to be broken down into different metabolites. And actually, some of the metabolites have been shown to also have antidepressant effects. So, some of the metabolites last a bit longer in the blood and in the brain than ketamine itself. So some of the longer lasting effects actually are thought to be, or have been proposed to be, mediated by this metabolite called hydroxynorketamine, or HNK for short. And we also tested that. We also decided, okay, is this HNK, which has been shown to be to have these antidepressant effects in mice, does it also depend on the protein synthesis? And we found that yes. So both drugs are actually triggering the same type of effect in the brain, at least in terms of protein synthesis and being mediated by the 4-EBPs. So that was another exciting finding that we had.
Okay, so here's a question. So is ketamine processed through the liver like many other drugs, through the P450 cytochrome enzyme cascade?
Yes.
Okay. So what about methylating ketamine so that the liver has a harder time breaking it down? And then when you methylate a drug, quite often its metabolites are methylated and they last longer as well.
That's an interesting possibility. I'm not sure why it hasn't been done, to be honest. But perhaps it's the potential risk that you may also extend on undesirable effects. So maybe methylating if the metabolite is proven to be effective in humans as well, which is something that it needs to be done. It's been shown in animal models, but not in humans, as far as I know. That will be the first step, and maybe working on the stability of that metabolite will be an important improvement. And the reason why I'm emphasizing in the metabolite is at least the data in animal models suggests that it doesn't have the addictive effects. And potentially it doesn't have either the hallucinogenic effects, because it doesn't block as effectively this receptor that mediates the NMDA receptor, which is the blockage of which is mediating these effects. So
it sounds like to me that you need to be making the metabolite a separate drug by itself, methylating it stays around longer, and administering it through intranasal so that it gets to the brain right away.
That's an exciting possibility. And then what we've shown is that basically in terms of protein synthesis, they're doing pretty similar things. They're both triggering and depend on the presence of 4-EBP. So it might be that just working on the metabolite may be a safer way to go. But yeah, I have to say that we still need to show that it does have an antidepressant effect on depressed people, not only in mice, because often.
Does the I'm rushing you for before the next break. Does the intranasal administration of ketamine allow people to function like they can still keep their job, take it in the morning, go to work, or do they still have a period of time where they have to just kind of hang out and wait for the effects to kind of subside?
They still have to wait for the effects, because there's, different people react differently, and you may have, someone that's more susceptible and start having some maybe perhaps hallucinatory or dissociative response that it needs to sort of wear off. And so it's always administered in a clinical setting, and often with a therapist present, and that is, and perhaps a nurse observing the effect, but for potential effects. So. Yeah,
I want to take our last commercial break. When we come back, we'll wrap up the interview. We're talking today with Dr. Argel Aguilar-Valles, and this is very fascinating. Major depressive disorder is a big problem in the United States and around the world. It makes people unproductive. They become prisoners in their own bodies, so to speak, and helping them free themselves from that self-induced prison is very, very important. Stay tuned. We'll be right back with more Superhuman Radio. Do you remember those delicious toaster pastries you had when you were a kid? You know, the rectangular sugar-filled snacks? Well, guess what? Legendary Foods has just made low-carb toaster pastry. This is the first of its kind, and honestly, these things are amazing. They have 3 to 4 net carb, less than 1 gram of sugar, and 9 grams of protein. You can eat them right out of the wrapper or lightly toast them. The only question is, which flavor, strawberry or brown sugar cinnamon? They're available at eatlegendary.com and Amazon. Hippocrates, the father of modern medicine, said that all disease begins in your gut. That's why it's so important to protect yourself with boosted immune system. If you drink coffee, tea, smoothies, or really any beverage in the morning, and you're looking for a tasty way to start your day and defend yourself against harmful bacteria, then I have just the thing for you to try. It's called the Ultimate Immunity Protection Stack, and it was put together by my friends over at Bioptimizers. Their immunity stack has 3 products which contain over 18 natural herbs and probiotic blends formulated to fight and eliminate bad bacteria like E. coli, salmonella, gram-positive and gram-negative bacteria, and repair compromised gut lining. It also includes psychobiotics, which help increase serotonin and happy chemicals to naturally elevate your mood, performance, and cognitive function with no side effects or dependencies. It's a great addition to your morning routine, and it tastes amazing. Just stir it into any beverage, sip, and enjoy. It's the ultimate way to boost your immune system right before the holiday season. Go to shrnetwork.biz/protect and use code SHR10 and save an extra 10% off on the. You won't find this deal or stack anywhere else. For fast shipping and the best deal, go to shrnetwork.biz/protect today. By now, you're aware of the cognitive benefits of nootropics. My friends over at Pure Nootropics are giving my listeners 10 to 30% off their already great prices on over 70 high-quality nootropics. Stock up on DHA so you can feel good after your holiday celebration, or try the Superhuman Stack to boost your brain and energize your day. Go to shrnetwork.biz/pure, that's PURE, and start saving today. Getting a massage post-workout is a proven strategy to facilitate better recovery. Getting to a massage therapist can be difficult and expensive, especially in these times. The solution is the Meteor, a heated massage ball from Milestorm. Reduce pain and soreness and expedite recovery with the Meteor's research-backed vibration settings and therapeutic heat. It's convenient for travel and works on any body part. Go to shrnetwork.biz/meteor and use code SHR15 for 15% off and free shipping if you buy 2 or more. Start recovering better today. Are you ready to change the way you age? Of course you are. That's why you're here. Juvicel is a new first-of-its-kind dietary supplement that includes 10 key research-backed ingredients shown in studies to support lifespan. Things like resveratrol, fisetin, quercetin, pterostilbene, sulforaphane, turmeric, all in a single dose. You may have some of these ingredients already, but Juvicel is the first to combine them all into a single product to support your lifespan. It's vegan, non-GMO, and sustainable. Live better longer with Juvicel. Go to shrnetwork.biz/live better. Use code SHR and save 20% off today.
This is the Superhuman Channel, doing reps with the weight of the world.
Welcome back. There's a ghost in my computer. Every time I go to a break, oh no, it didn't do it this time. It changes my camera. We're talking today about ketamine for major depressive disorder. This research shows how ketamine works. This is fascinating research because this show, we love discussions about mTOR, AMPK, ketone bodies, inflammation, the microbiome. What role does the microbiome play, do you think, in depression? Obviously, when we talk about inflammation, we're talking about the army of the immune system. When we talk about the army of the immune system, we're talking about the gut, because 85% of the immune system resides in the gut. How many of these people that have major depressive disorder have horrible gut problems too? Any idea?
I don't know the exact number, but it's probably quite large. There is quite a lot of evidence that there's a lot of gut dysbiosis, that this alteration of the more healthy gut microbiota in depressive disorder. And as you say, all of these different bacteria not only control the way we respond to infections or inflammations, but they also, secrete psychoactive substances like metabolites of the bacteria that enter our bloodstream and then affect the way our brain works and performs under, stressful circumstances and so on and so forth. So it does have a major role. Particularly in when you have people that, one way to cope with stressful situations is usually go for a bad diet, a high carbohydrate diet. That will change. That will contribute to this. It's a vicious circle. It starts with something that maybe it seems that it's helping you to cope, but eventually it might make things worse because it's altering your body physiology and the way your body responds. To all of these challenges.
I'm convinced that boutique coffee. And we can thank my Italian and Latin ancestors for this, because we love dark coffee. We love that black coffee, But I'm convinced 79% of Americans drink coffee every day. Over 70% of Americans complain about having digestive issues. Autoimmune disorders are on the rise. Diseases like Parkinson's disease and ALS and multiple sclerosis are now being tied to an autoimmunity. When you put all these things together, depression tied to inflammation. Inflammation starts from the gut because the inflammatory cytokine. So I've recently given up coffee for good. I'll never drink another coffee. I'm 62 years old. I've drank coffee for most of my life, but it's no good for me. It hurts me. It hurts me. But I overlook the pain, because every morning when I drive down Highway 42, my favorite Starbucks is there. And this is what goes through my mind now. I drive by, I look at Starbucks. My brain tells my microbes, there's coffee. My microbes go, feed me, feed me, feed me. They create chemicals that tell my body, why do I want coffee so bad? It's because my gut is telling me, my brain, feed us, feed us. So now I go in my head, F you, die, and I drive by. I keep on going, because I'm convinced that coffee is causing problems in the population today. My mother and father drank coffee. They drank 4 ounces of coffee, and you could see through it. Today, the coffee is so dark, the turbidity of it's like a liqueur, and all that stuff. It's like all those particles suspended in that coffee. And then what do people do? They drink it on an empty stomach. It erodes the mucosal barrier. It starts to cause erosion in the gut. And I'm going to tell you right now, 50 years from now, they're going to find out that coffee is destroying the guts, and the guts is destroying our bodies. So.
Yeah, no, it's yeah, you're right. Like, as with everything, the poison is on the dose. So the fact that is so, taken so much all the time, and as you said, like past generations will take a coffee, but it was a cup this size, right? Where it was now we take like our large
20
or whatever
ounces.
it's
20
called.
ounces. Yeah, yeah,
Yeah,
20 ounces.
it's
Yeah.
huge. And it's as you said, in mass production of anything, it has risk. Mass production of coffee, it implicates using pesticides and stuff like that. So you're consuming all of those things, and it's, as you said, it's not once in a while, it's every day, several times a day. So it's bound to have some effects. And I will add to that, like, if I will be perhaps more, I don't know, yeah, coffee in excess is not great for sure. But also, like, a lot of people will take it with sugar, like, and just the amount of sugar that goes with coffee, it just, like, it's stratospheric, and that also has like major effects on these
Feed,
refined sugars that we have everywhere are not are bad.
sugar feeds the pathogenic microbes in the gut. If you want to kill them, you have to starve them. Okay, so there are currently ketamine clinics out there right now treating people with major depressive disorder in the United States and Canada and around the world. So what do you hope those clinicians take away from this research that you've just performed?
Well, I think at this point we are this particular project, it's still in an early stage. So I would really hope that in the next few months we'll be able to take it to the next level and really identify, as I mentioned before, those essential targets of the 4-EBP that are mediating, like what we can call perhaps the ultimate targets of ketamine that are responsible, and that then these can be used actually to design better therapies. What I will also like to see more, and which again is not very often, and again our research is not necessarily focused on that, but is this better recognition that different types of depression need to be treated differently. So there is an effort out there, obviously, to identify these markers. For example, the inflammatory markers. So you will go for a profiling, ideally, and then see if you have your inflammatory markers highly elevated or not, because as you said, there's people that aren't with that. But that's not part of our, of our diagnostic process for depression. It's usually based still on the questionnaire that therapists or a psychiatrist may administer to you, or even a general physician, and say, okay, yeah, you fit the criteria for depression, take your medication. Didn't work, take this other medication. So it's still a guessing process that actually hurts people, because you have to wait for months to these things to work. So that's not ideal, and that's why the idea of improving ketamine and making it safer, and perhaps then using it as a first line of therapy, it will actually be another major improvement in the way we treat depression, and also identify, because there's probably people out there that won't respond to ketamine. So that's important to identify as well. And then maybe that's those people actually are not necessarily the same as the people in terms of the disease characteristics. They're not the same as the people that respond to ketamine. So all of this work in recognizing what individual factors lead to a person to be depressed, it will be fundamental to really have effective therapies for most people, for a great majority, which is a problem these days, that a lot of people are really not responding to typical antidepressants.
Adam Kovacic says apparently ketamine is great for ME/CFS. I don't know what those acronyms are. Do you know? Cerebral.
No, I don't know. Yeah, I see it there. I'm not sure what he means.
Yeah, Adam, could you spell that out, please? Also, he asked if it would be good for people with autoimmune disease and chronic inflammation. Is there any anti-inflammatory benefits of ketamine that you're aware of?
We have seen in our own models, when you have chronic stress in mice, it's you will you have elevated cytokine levels, and we have observed that ketamine is able to bring those down. So it can have certain anti-inflammatory effects. So what I would like to see is more data in patients as well, because as you know, patients are much more diverse than our laboratory mice that they're basically clones from each other. So they all respond fairly similarly. But when you're working with people, it's a different story. But yes, there is some evidence that it can have some anti-inflammatory. It's not its main thing, but it can cause the inflammation to be reduced at a certain level.
So my next guest is Alex Leaf.
Yes.
And he just typed that MECFS stands for myalgic encephalomyelitis,
Yes.
chronic fatigue syndrome. Any evidence that people with chronic fatigue syndrome would benefit from ketamine?
That's a good question. I'm not aware of any study in that regard. That just means it might not be tried already. People have been focused a lot on, for example, these rapid effect of ketamine on, for example, suicidal ideation. So that's been a lot of the focus. But I haven't seen like chronic fatigue or more this type of depression. I mean, chronic fatigue on itself I haven't seen, but it's also beneficial for people with depression that have similar symptoms to chronic fatigue syndrome. So it may work. It probably has some beneficial effects, but it will need to be proven in a clinical study.
Dr. Aguilar-Valles, I want to thank you for coming on the show today. It's been a fascinating discussion.
Thank you very much, Carl.
Take care of yourself.
You too. Bye.
We're going to take one quick commercial break, and when we get back, we're going to be joined by Alex Leaf, who's helping me behind the scenes here understand acronyms. And we're going to have a fascinating discussion about the upcoming rush or push to get pregnant women to take the new COVID-19 vaccine. There is no evidence that it's dangerous, but there's also no evidence that it's safe. And last I checked, people always wanted to err on the side of caution. So we're going to have a fascinating discussion. Stay tuned. You're watching and listening to Superhuman Radio. We'll be right back. Hippocrates, the father of modern medicine, said that all disease begins in your gut. That's why it's so important to protect yourself with boosted immune system. If you drink coffee, tea, smoothies, or really any beverage in the morning, and you're looking for a tasty way to start your day and defend yourself against harmful bacteria, then I have just the thing for you to try. It's called the Ultimate Immunity Protection Stack, and it was put together by my friends over at Bioptimizers. Their immunity stack has 3 products which contain over 18 natural herbs and probiotic blends formulated to fight and eliminate bad bacteria like E. coli, salmonella, gram-positive and gram-negative bacteria, and repair compromised gut lining. It also includes psychobiotics, which help increase serotonin and happy chemicals to naturally elevate your mood, performance, and cognitive function with no side effects or dependencies. It's a great addition to your morning routine, and it tastes amazing. Just stir it into any beverage, sip, and enjoy. It's the ultimate way to boost your immune system right before the holiday season. Go to shrnetwork.biz/protect and use code SHR10 and save an extra 10% off on You won't find this deal or stack anywhere else. For fast shipping and the best deal, go to shrnetwork.biz/protect today.
New Mass Pro Synthogen X2 just upped its own legendary game to distance itself even further from the rest of the now has double the key active ingredients. If you've ever wondered what steroid-like recovery feels like, Synthogen X2 delivers. See why others compare it favorably to powerful bodybuilding drugs at synthogen.com. Mass Pro Synthogen. When you train with it, you'll gain with it.
Do you remember those delicious toaster pastries you had when you were a kid? You know, the rectangular sugar-filled snacks? Well, guess what? Legendary Foods has just made low-carb toaster pastry. This is the first of its kind, and honestly, these things are amazing. They have 3 to 4 net carb, less than 1 gram of sugar, and 9 grams of protein. You can eat them right out of the wrapper or lightly toast them. The only question is, which flavor? Strawberry or brown sugar cinnamon? They're available at eatlegendary.com and Amazon. TaylorMade Health is focused on making sure you're able to perform and look your best. They are a leader in game-changing supplements and cosmetic products. Whether you want to increase strength, expedite recovery, facilitate soft tissue repair, or reduce deep wrinkles, TaylorMade Health has you covered. TaylorMade Health is also the home to Dr. Seed's products such as BPC, BPC Plus, and the Chill Pill. All of my listeners can now get 20% off their first order with code TRY20. That's TRY20. This code can even be used on subscription orders. Visit shrnetwork.biz/try20 today and use code TRY20 for 20% off your first order. Whether your goal is to build muscle or burn fat, you'll find everything you need at Redcon One. Need help getting a good night's sleep? Try Fade Out, or the most popular pre-workout supplement on the market today, Total War. Sign up for their new Transformation Challenge and win $10,000, or shop for apparel that people at the gym will know that you are serious about your training. Need a testosterone booster that works? Check out Boomstick. Whatever you need, you'll find the best quality supplements on the market at Redcon One. Go to redcon1.com. That's REDCON1.com, or go to superhumanradio.net and click the Redcon One banner ad today.
This is the Superhuman Channel, where we use oxygen for the power of good.
There he is. He's in the background making me look smart. How you doing, Alex?
I'm doing great. How are you?
Good. Welcome back. So Alex Leaf made an interesting post the other day, and Elisa said, you have to have Alex on the show. And it's actually, and I want to do something. I am not a virologist. I'm not a doctor. I'm a critical thinker. I consider myself fairly intelligent. Alex is probably a genius. And well, you are. No. I'm being real. I'm not blowing smoke. You're a very highly intelligent individual. But also, Alex is one of the more conservative people I know. Alex rarely says stuff to get attention. He never says stuff that isn't founded in science. And you made a post the other day. You and your lovely bride, Brianna, are wanting to have a baby. We are in the midst of COVID hysteria right now, a disease that if you're 75 years old or under, your risk of dying from surviving is 99.x. You can argue about the number after that. So most of us, I feel like I'm 62 years old. Maybe I had it already. Maybe I didn't. I'm not worried about it. I'm not worried about vaccines or anything like that. But invoking a vaccine on a pregnant woman is a completely different thing because of transgenerational effects and so on. Talk about the post that you made the other day.
Yeah, so I guess the post really started just because certain news outlets, the CDC specifically said that, the vaccine should be offered to pregnant women and there's no reason for them to consult with their gynecologist or whoever like their primary care physician is before they agree to get it. And to me, it was just kind of like, wow, okay. The CDC followed it up by saying that, experts said it's not an issue to get in pregnancy and there's no reason to be concerned. And that I tweeted about that on Twitter kind of with the tongue-in-cheek comment that, expert opinion isn't, as good as scientific data unless it's the CDC saying so.
Right.
And it led to me actually writing a post about it on Facebook that essentially says, look, the fact of the matter is that we have 3 clinical trials that have been done, one by Pfizer, one by Moderna, and one by AstraZeneca. And every single one of those trials, as part of their exclusion criteria, kicked out pregnant women. They said, we don't want you in our trial. And it's understandable why they would do that. You're testing.
They don't want the liability.
Yeah.
Right.
So we don't have data on pregnant people, like at all. And what that means is that forming any sort of conclusion about them, be it, it's safe or it's dangerous, falls under what's called a fallacy of ignorance, which is when you form a conclusion when there's no evidence to be the basis of that conclusion. And so that was basically my post, was just a reminder to people that, hey, you have a right to get this vaccine if you want to get it. But, if you are currently pregnant or you're intending on becoming pregnant soon, then you also have a right to not get the vaccine because of the unknown effects it would have on both pregnancy outcomes and any fetal outcomes after the woman gives birth. So, you know, I'm not the only one who shares this opinion either. The World Health Organization has said that they don't recommend the vaccine be given to pregnant women due to the paucity or the lack of data. And the United Kingdom's also said that. Australia is still up in air. Australia hasn't decided whether they want to make that recommendation or not. And so they haven't said to give it or not to give it to pregnant women yet. They haven't put their foot on the ground. The US has said, go ahead and give it. And so my whole post was just a reminder to people that we don't have any data available. None at all. And, you know, from a precautionary principle, you want to make sure it's safe in pregnancy for both yourself and for the baby.
So let's stop there for a second. So let's talk about this. Let's talk about the mother's life first. You had statistics that you got, I think, from the CDC of the cases of pregnant women contracting COVID and surviving it. Yeah, yes. There's a little alien behind you. I didn't want to scare you.
Yeah, I know. She likes to climb on my bookshelf.
So well, maybe she wants to read a book. So yeah. What do the statistics look like? How is a pregnant woman at far greater risk of dying from COVID than a non-pregnant woman of the same age?
Yeah, so this is an excellent point, because that's really the question is, you know, when you decide if you want to get the vaccine or not, you're dealing with no data at all. But what's the alternative? The alternative is your risk of contracting COVID, right? Because the trials have shown that it reduces the risk of contracting COVID. Now, I mean, the studies have limitations, but without a doubt, it does show that it reduces the risk of contracting COVID in what would constitute the age range that women can become pregnant. So what's the risk if you're pregnant and you contract symptomatic COVID? So a lot of people get COVID, they don't even have symptoms, right? Or they're very, very mild. This is, if you look at, the CDC did an analysis of 400,000 women that all had symptomatic COVID, like they were experiencing the respiratory, you know, symptoms of having this infection. And what they found is that when they corrected for, you know, underlying health conditions, age, and race, they found that being pregnant, for every 1,000 women that contracted symptomatic COVID, your risk of being admitted to the intensive care unit was about 10 pregnant women per 1,000 that became infected, compared to 4 for every 1,000 non-pregnant women. Right. So, I mean, that's, you know, a 250% increased risk of being admitted to the ICU. But in absolute terms, it's literally an additional 6 people for every 1,000. So yes, your risk is higher, but it's not that much higher.
Yeah, but how many of them die? But now here's the real important. How many of those pregnant women die?
Pregnant women, 1.5 for every 1,000 compared to 1.2 for every 1,000 non-pregnant. So a 0.3, so a third of a person difference. That means 1 more pregnant woman would die for every 3,000 people that got symptomatic COVID compared to non-pregnant. And I mean, that number would manifest as 4.5 versus 3.5 people for every 3,000.
Okay, so the protection for the mother is negligible at best. Negligible at best. It's statistically significant, because everything's statistically significant in a study when the numbers are different. But the reality is, you're talking about 1 more woman per 3,000 pregnant women versus non-pregnant women. So now let's talk about something that should really be considered. If you're a factory, if you're a factory making a human being, then what it will do to the human being that you're making should be discussed, number one. So let's look at the positive side. If a mother or a woman of childbearing age gets the measles or the mumps, and she gets better from that, is it not true that her offspring has the antibodies and is protected against that? Isn't that what herd immunity is all about?
Well, I wouldn't say that that's what herd immunity is about, but it's certainly, one of the benefits of having a mother that's been exposed to these pathogens is the immune memory is able to cross the placenta and help protect the infant during the early stages of life until their own immune system is able to take over. And what I mean by that is the immunity does not last forever. That's why everyone gets chickenpox, for example.
Right.
Because the immunity is only short-lived while those immune cells are circulating in the baby's body before they die. And that's actually one of the potential benefits of the vaccine as well, is that the vaccine, what ends up happening is it just codes for a spike protein that exists on the virus that our immune system uses to identify this virus. Your cells start making it. They say, hey, this is a foreign protein fragment. I'm going to put it on my cell surface. Immune cells are going to come touch it and be like, wait, this is foreign. We need to alert our T cells. Our T cells are going to come in and be like, yep, we need to start attacking this, and we need to make specific antibodies that are structurally, that can work with this protein basically to neutralize it. And so that's how you get immune memory from this vaccine. That immune memory, just as if you had a natural infection, that immune memory will go with you into the baby and help protect it, theoretically, during the first however long those immune cells last in its life.
So there could be a potential benefit to the offspring in the early stages of its life from the mother being vaccinated. Okay, so that's a plus. That's a plus. Now, what do we know about mRNA type vaccines at this point in time? This is a very new type of vaccine that has the ability to modulate the immune system, correct?
Yes and no. So mRNA, how do I want to say it? Like mRNA drugs have been researched for at least 30 years. Okay. So we have a lot of research behind them, figuring out how they work, how we can make them as efficient as possible, safety data. We have studies in rodents, for example, showing that mRNA, this vaccine, doesn't affect any pregnancy or fertility outcomes. The question is, does that apply to humans? There's been a lot of misinformation perpetuated about mRNA vaccines due to people misunderstanding kind of how they work. And so we have decades of data with them. It's just, the question is that, in those decades, why hasn't it ever been used in humans for anything up until this point? And there's two potential answers. One answer is more cynical, and it says that, well, we really, this vaccine, had emergency use authorization before proper safety testing. The previous data in some cases did show that it had harms. For example, we've used mRNA vaccines against coronaviruses in cats, because cats are especially prone to coronaviruses for things like eye colds. And they've been shown to have harmful effects on cats, or I shouldn't say harmful effects, but they've been shown to have adverse effects in humans, right? So that's a cynical view. The more kind of beneficial view or optimistic view is that we literally poured billions and billions of dollars into research and development, and demonstrated what can be achieved if the entire nation and the entire world, in fact, agrees that something needs to be researched and brought to market. And this is how quickly it can happen in a safe and effective manner. So there's two views. I don't know which one's correct. I don't think anyone does, because it's just a matter of opinion. But my position as far as pregnancy goes is that I have not seen any data at all to suggest that there is a reason to not get the vaccine in pregnancy. Nothing. But there is no human data at all. And so the precautionary principle for me suggests that I want to be abundantly cautious, and I want to wait until future safety data in pregnant women is available, and it will be available.
That seems reasonable. That doesn't seem over the top. It doesn't seem like tin hat wearing idea. It seems very reasonable. The last interview we talked about ketamine and how ketamine affects mTOR it depends on mTOR for it to work in its antidepressive effects, and that taking rapamycin and ketamine at the same time in rodents mitigated its effect, but it worked in humans. So there you have an example where just because something happened in rodents doesn't mean it's going to happen that way in humans.
Well, there's a lot of examples about that. I mean, countless. And a lot of it fundamentally comes down to, for example, differences in metabolism. Rodents have a body-specific metabolic rate 7 times faster than humans, which means that they're going to metabolize compounds and detoxify certain drugs and the such differently than they are humans. Now, again, safety data in rodents seems optimistic. My only concern is that we don't have any data in humans. And so when I made this post, I specifically said at the end of it, I said, look, the whole purpose of me saying this is not to instill fear. I'm not saying, hey, you shouldn't get the vaccine because there's a lack of data. What I'm saying is that there's a lack of data, and now you need to contrast this lack of data with the risks of COVID in pregnancy, which we discussed earlier. Basically, an additional 6 people per 1,000 can expect to get severe COVID, statistically. So if you are willing to accept that risk, then I think it's a smart move to wait until more safety data is available to get the vaccine. If that risk is too great for you, then I fully support your decision to get the vaccine. My position is I want to support the position that people take, and I want to support the
data,
their ability to make that choice for themselves. I don't want anything forced upon them.
But more importantly, we have a population out there that's saying, trust the science, trust the science, trust the science. There's no science for this. So that same population should be going, well, there's no science for this, so we really don't know what you should do. But instead they're saying, oh, it's safe, go ahead and use it. So it's trust the science when the science favors our position. But when there's no science at all, just listen to us.
Yeah, we're experts. It's fine. Yeah, exactly.
Well, I want to invoke something else that we didn't plan on talking about, but it's fascinating to me because I know Elisa and I are going to talk about this on the first Casual Friday at the end of the month. And I think that you may have had some discussions about this on social media and gotten some backlash. Recently, Cosmopolitan put some really overweight women on their cover and said healthy or the new healthy or something like that. Mm-hmm. And first of all, you can't look at somebody and tell if they're healthy or not, right? If we could, man, we wouldn't need all that diagnostic stuff in the hospital. We just look at them and say, oh, you got cancer. You better go. So that's first of all silly, but more so.
Is it?
Well, no. What is silly about this whole discussion is, and something I've talked about on this show for years, you know, you can buy, for those of you old enough, a Chevy Vega, you could buy a what's that little Cooper? And you can pull a fifth wheel with it. And you'll probably be able to get across the country one time. But you may not be able to get across the country the second time, because even though that car looked like it could do the job, it starts to wear out and break down. And so this idea that really obese people are healthy is only if you take a snapshot in time of them. If you continue on that path over 5 years, 6 years, now you see the cumulative damaging effects of their metabolic system under that weight. So sure, the gal who's 22 years old and she's carrying 200 pounds of body fat and she goes and gets blood work done and the doctor goes, you're healthy. Yeah, you're healthy today, but you can't stay like that and be healthy. And we know that already. So I think you may have commented something like that on Facebook. And the reason I'm setting this table is I want to talk about pregnancy for a second. So pregnant women, by and large in the United States, think that when they're pregnant, it doesn't matter. In fact, we have pediatricians, not pediatricians, we have obstetricians telling their patients, don't worry, eat whatever you want. And these people women gain 150 pounds during pregnancy, when really all they needed to gain was maybe 40 or 50 pounds tops to deliver a healthy baby and not destroy their own body. But what are we talking about here when we talk about pregnant women, given the state of what women think pregnancy weight looks like. How about those women that are so heavy, so they put on so much body fat that they're actually more susceptible from dying from COVID? Am I being a jerk here by imposing that question?
I don't think so. I think that it's well established that obesity, if you take, let me put it this way. So probably a couple months ago, I did an entire article on how obesity affects immune function. And if you take the immune system of a 24-year-old person who is obese with a BMI of around 33, 34, so not even morbid obesity, this is literally grade 1 obesity.
Right.
And you compare their immune system functionality to someone who is of a normal weight, their immune system is equivalent to that of a 55-year-old. And so, and then there's a bazillion different mechanistic explanations to explain how obesity causes immunosenescence. And this is why obesity is such a huge risk factor for respiratory diseases like COVID. It's because it causes your immune system to be dysfunctional. It causes immunosenescence. So you're not able to mount as robust of an immune response when you encounter pathogens. And that's well established in the scientific literature. Obesity is a huge risk factor for immune
mortality from this virus and mortality from this virus.
Yes, exactly. And that's been observed with COVID. That's been observed with like everything, that every pathogen that we're aware of, including COVID. Some of the earliest data we had was showing that people with obesity were at like a 3-fold increased risk of mortality. Now, and this is also exactly why older adults are at an increased risk, is because your immune system becomes less functional as you get older. It's a normal part of aging. That's why people over age 75 in the US make up 60% of all deaths in the US, right? And people below age, 45 make up 0.8% of all deaths.
Right.
And in between there, you have, an exponential curve where the older you get, exponentially more deaths because of immune system dysregulation, and also other factors like malnutrition, having low amounts of muscle mass, typical things that happen with aging, comorbidities. People just tend to become more metabolically dysfunctional as they age as well. And so, yeah, with pregnancy, it's used as an excuse for a lot of women to kind of pig out, eat whatever they want, gain a bunch of weight. And this might not necessarily be a problem depending on what your starting weight is, right? But if you're someone who's already overweight or obese, you only need to gain about 15 to 20 pounds during your pregnancy. And yet your weight just continues to go up because you already have poor eating behaviors and habits in place, and you're just capitalizing on those now. And that does damage the baby. You're at a greater risk of gestational diabetes, which is harmful to the fetus. And can cause premature births. You are literally starting to program the epigenetic changes in their DNA that can make them more susceptible to obesity later on in their life. Mm-hmm. Even if you don't care anything about yourself, I mean, fundamentally, you should probably care about your kid, right?
Right.
Like, we know that what you do when you're pregnant is going to impact your child's life way into adulthood. That's not good.
You know what's really funny? On the side of a jug of colostrum, it says it's not recommended for pregnant women. On just about every dietary supplement in the world, it's called a CYA. Cover your ass. Every supplement manufacturer in the world puts, if you're pregnant or lactating, talk to your doctor before taking the supplement as a minimum. And as a maximum, it says not recommended for pregnant women or lactating women. Now, they haven't done the research to prove that it's harmful for pregnant women or their babies that they're breastfeeding. But because they haven't done the research, they say, don't take it, because they don't want the liability of somebody taking it and having a child on the spectrum and saying, oh, it was that supplement I was taking during pregnancy. But yet the CDC, the master controller of disease and research in this country, has no problem telling you, we have no research to prove that it's safe, but we say it is. We're experts. You take it. Think about the difference. Think about the balls on the scientists at the CDC who said, yeah, no, it's okay. Don't take colostrum because we don't know what that'll do to you while you're pregnant. But yeah, you can have this vaccine, no problem. And I'm going to say something else real quick. I believe in vaccines. People think I don't. I believe in hormesis. The earliest vaccines were during the Black Plague, where they actually scraped the pustules from people who survived the Black Plague. And they took that and they scratched the person's arm open and they rubbed that pus in. And the person got mildly sick for 2 or 3 days, and then they were immune to the Black Plague. This is where vaccines came from. Vaccines work by hormesis. If you take just a little bit of the poison, you become strong enough to resist it over time. But what happened was AstraZeneca and Senegenica and all these other pharmaceutical companies thought, wait, how do we put that into a multi-injection vial that's shelf stable for 5 years? Oh, well, we got to add all these other things that have nothing to do with making the vaccine work better, but making it marketable and profitable. And that's the stuff that I don't like in there. And the last thing I'm going to say is vaccines work, but the vaccines that were being forced upon you today, that you don't even have a choice, that's not good science. I don't care what it is. That's not good science.
Carl, can I say one more thing?
Please, we have all the time you want.
Yeah, I also want to mention too, because with everything that's going on right now, people are very divided. People are tribalistic. They like to make enemies out of others. And the message I want to stress is, don't shame people for their decisions. People are allowed to look at situations and decide what is best for them and their body. And especially with the vaccine, it's really easy to throw around claims of selfishness, like, oh, you won't get vaccinated because you're selfish, you don't care about the community or whatever. And the reality is that it's selfish for you to think that you are allowed to impose your desires on another human. I mean, the fact of the matter is that every single clinical trial we have on this COVID vaccine, they all excluded children. They excluded pregnant and breastfeeding women. They excluded people with immune disorders, and they excluded people who have allergies to it. In particular, someone with an allergy, are you going to shame someone who decided not to get the vaccine because it would cause an anaphylactic shock in them? Like, that just seems so absurd when you put it that way. But It's like, you have no idea why someone decided not to get the vaccine. Who are you to believe they're a lesser human because of their decision? Like, it's harmful in people who are allergic to it, first of all. And that's every single government organization says, nope, these people have a medical exemption. They should not get it because, they could die. We have zero data in pregnant and breastfeeding women. Why not be cautious? We have zero data in people who are immunocompromised, like an HIV patient. Why not be cautious?
What about rheumatoid arthritis? What about clear autoimmune disorders, rheumatoid arthritis, Hashimoto's disease, Addison's disease? These people have compromised immune systems that are attacking their tissue now. Shouldn't they be allowed to opt out if they want to opt out of a vaccine?
I would think so. The vaccines let some of those people in. One of the studies, I think Pfizer had 40 out of their 30,000 peoples had rheumatoid arthritis. So, they were included in the study, but not in numbers that would allow for any meaningful analysis of that specific subgroup. And even there was 240 adverse events in the vaccine group. It could have been all of them involved people with rheumatoid arthritis, but we don't know.
Yeah, because it was blinded. Yeah, right.
And then all these studies excluded children. 2 of them involved people over 18. I believe the Pfizer trial went down to allowed people that were 16 and older to get the vaccine with with parental consent. But in children, zero data on how the vaccine might affect them too. So, God forbid people want to start vaccinating their kids with it with zero data on how it impacts anything, especially because they're such a low risk group, right? And that's another thing is my position from the start of this vaccine is that we should really be prioritizing the people that are dying from COVID. Like, If you are over 75 years old, you should probably get the vaccine because you're making up over 60% of deaths.
Yes.
And that's actually another concern with the studies, is every single trial, in each one of them, less than 5% of the study participants were over 75 years of age. And we know that, again, elderly people are less responsive to vaccines because of the immunosenescence. They do not develop immunity as well as a younger, healthier person does. So the question arises, will the vaccine even be effective in them? Do they need a different dosing schedule, et cetera, et cetera? We can't figure any of that out from the data we do have.
Right.
Now, that being said, even though there is no data, if I was over 75, hell yeah, I would be getting the vaccine. Why? Because my risk of dying is so great that going and assuming the vaccine is going to work is worth it. It really is. But when you have such a low risk, such as being, a healthy, young to middle-aged adult, or even if you're a pregnant woman, your risk is so low that I think there's enough room to just take a step back and be like, I just want to wait until there's a little more safety data. And those decisions shouldn't be shamed.
I agree with you. So we're coming to the end of the interview. I want to send people to your website. Your website is alexleaf.com, correct?
Yep.
You've got some great blog posts there. You've got a blueprint for fat loss there. But also, do you still do nutritional counseling?
Yeah. Well, I do consults. If people just want to talk to me, then yeah, I do consults for sure.
And the way to get in touch with you is through the website, alexleaf.com.
Yep. Just on my contact page.
Yeah. Alex is worth talking to because Alex lives the life that he promotes, and he knows what works and what doesn't. And as you can see, Alex is very centered about his opinions. If science provides insights into a specific direction, Alex is not going to discount it. And so he's the kind of guy that if you are trying to get your body in shape for 2021 and you want to talk to someone sensible who isn't going to tell you, well, you got to eat keto or you got to eat carnivore, or no, you got to eat only cardboard. Alex will have you eating a diet that you enjoy eating, because the diet that you enjoy, you will most likely stick to and you'll get results from. He has you graduated from Bastyr with a degree in nutrition, right?
Yeah, my master's in 2016.
There you go. So he's not just some guy who took a course at some health club and is calling himself a nutritional counselor. Go to alexleaf.com. Check him out. Alex, thanks for being here today, brother.
Thank you for having me, Carl. It was fun.
Yeah, I'll talk to you again soon, okay?
All right, bye.
And that's it for today. We have great shows all week long. Please share the show. Help the show blow up. Share the show. All right, we'll see you tomorrow with more Superhuman Radio. Thank you for watching and listening today.